Hi, so welcome to this final session in the session where we're looking at risk of bias and design justification. And in this mini session, we're going to be looking at the justification for using a stepped wedge cluster randomized design. So as a recap, compared to the parallel cluster randomized trial, the stepped wedge cluster randomized design is probably at increased risk of bias. And it also has some added other complexities around its implementation. So the objectives in this session are to outline the common perceived justifications for using a stepped wedge design, and then consider and critique some of the commonly proposed justifications. And the commonly proposed justifications for using a stepped wedge design include that the intervention is going to be rolled out irrespective of any evaluation, that it's a socially acceptable design, that pragmatic and logistical reasons mean that it's an easier design to roll out, and that it's a statistically efficient design. So we're going to look at these four proposed justifications and have a little bit of a critique about each of them. So first of all, the popularity of the stepped wedge trial is clearly growing. So this graph here illustrates how its popularity is growing by counting the number of citations of stepped wedge classifications in PubMed classified as randomized trials up to February 2021. And we can see that there's a marked stepped change over the past decade. So the reported reasons for adopting a stepped wedge trial design were evaluated in a review of the 32 stepped wedge trials that had been fully published in 2017. Now of note, a large number of these trials, 40% of them, didn't report any justification for opting for a stepped wedge design. Of those that did report a justification, the commonly reported justifications were that all sites get the intervention, that resource constraints meant that the staggering of the rollout using the stepped wedge design meant for a more feasible design. Other people cited its ethical advantages, and a smaller number cited its methodological power or statistical efficiency advantages. So what needs to be justified if we're running a stepped wedge design? So first of all, we need to justify the use of cluster randomization, which we've considered in some detail in previous sections. But we also need to justify the need to roll out the intervention to all clusters. Why do all clusters need to be exposed to the intervention? And the need for the staggered rollout of the intervention. Why is it not possible that we can give the intervention to half of the clusters at the same point in time? And we're going to look at these two aspects in more detail here because we've already looked at the justification for using cluster randomization in previous sections. So why is justification needed? And it's worth reminding ourselves why it's important to justify the use of this design. Because after all, many of the reported stepped wedge designs we saw didn't report any justification at all. Well, we've seen already that it requires a model-based analysis. It's a design that is confounded on time by design, therefore requires a model-based analysis. The assumptions underpinning many of the models that are used might not be appropriate. It's also more complicated in its design, and because it's more complicated, it might mean that it's at greater risk of not delivering on its objectives. It also might increase the number of individuals or clusters exposed to the intervention. And after all, this intervention is of unknown effectiveness. We don't know whether the intervention works. That's why we're evaluating it. So therefore, there is a risk that it might increase the number of participants exposed to a potentially harmful intervention. So let's look at some of the proposed justifications. So the first proposed justification is that the stepped wedge design provides a means to conduct a randomized evaluation. Well, we know that interventions are frequently rolled out with any robust evaluation. Now, sometimes the rollout might be sequential because of a limited resource or capacity to roll out this new intervention to the entire health system at the same time. Or it might be that there is planned to be a gradual rollout of this intervention so as to allow the possibility that sites might learn from earlier implementation in such a way that the intervention is adapted as more is learned. Now, if in either of these situations the stakeholders can be convinced to randomize the order of the rollout, this therefore means that the stepped wedge cluster randomized design might provide a means to evaluate this intervention in a robust randomized way, as well as allowing for the staggering of the rollout. However, there is a but. If the stakeholders can be convinced of the benefits of randomizing the order of the rollout, remember, we're talking about settings where there was no planned randomized evaluation, just a sequential rollout. If those stakeholders can be convinced to randomize the order of the rollout, because this will increase the robustness of the evaluation, then it might also be possible to convince the stakeholders of the benefits of randomizing to align with a parallel cluster trial. The second justification that's often put forward is that it might facilitate cluster recruitment. That is, it's a socially appealing design. So sometimes stakeholders can be reluctant to participate in a trial unless they're guaranteed to receive the intervention. So these desires and a priori beliefs that stakeholders might hold might mean that they are somehow convinced of the benefits of the intervention even before it's been evaluated. And therefore, because the stepped wedge cluster trial provides them with a guarantee that they will eventually receive the intervention, they may be more likely to participate in a trial if it's designed as a stepped wedge trial. However, if this is going to be used as a justification, then researchers and investigators should really demonstrate that clusters are indeed more likely to participate in a stepped wedge trial. And the stakeholders should be fully informed about the alternatives, such as a parallel design and the waitlist design, where all clusters receive the intervention at the end of the study, and also of the benefits of randomization to a parallel design. So this should only be used as a justification when the stakeholders or the cluster gatekeepers are fully informed of the alternatives. Justification 3 is that the stepped wedge design can create a logistically feasible design. So sometimes there may be limited resources or capacity to roll out the intervention to the entire health system at the same time. For example, maybe it's planned that 10 clusters are required to receive the intervention, and maybe it's not feasible to roll this intervention out to the 10 clusters at the same point in time. So this therefore means that the sequential rollout in the stepped wedge design can be very appealing. However, the sequential rollout in a stepped wedge design can bring about its own logistical issues. So for example, research ethics approvals for all centres or all clusters have to be obtained in advance of starting the trial so that all clusters are ready to implement the intervention according to their allocated schedule. In addition, a parallel design can also be conducted in a staggered way, and we'll look at this in more detail in upcoming sessions. And then finally, justification 4. The stepped wedge trial is often thought to have increased statistical power. So when we're conducting a stepped wedge design, the number of available clusters might be limited, either because of limited number of clusters available or a limited trial budget. Now, in those circumstances, it might well be the case that stepped wedge designs might achieve the desired power with fewer clusters than the parallel trial needs. And it even might be the case that with a small number of clusters, 80 or 90% power might not even be achievable under a parallel design, but can be achieved under a stepped wedge design. However, in exactly those settings where the stepped wedge design looks to be more powerful, it can also be at greater risk. So the stepped wedge design often looks to be a more powerful design when the number of clusters is small. But at the same time, stepped wedge designs, remember, are at risk of these analytical biases, have to make the assumption of a homogeneity of the secular trends, and this might not hold. And we also have to be mindful of the need to use small sample corrections in settings where we've only got a small number of clusters. So yes, in some settings, the stepped wedge design can have increased statistical power, but this will not always be the case. And in those settings where the stepped wedge design looks to have increased power, it's probably in settings where we're having to make a large number of analytical assumptions, which might not be tenable. There are also other considerations. So the study duration, for example. So it can be imperative to provide an evaluation of an intervention's effectiveness in a shorter amount of time, perhaps because the funder requires this. Now, whether the parallel design or the stepped wedge design will be shorter depends on the specific circumstances, and neither one nor the other will necessarily be longer or shorter than the other. Even when visually represented, the stepped wedge design often looks like it's a lot longer. In practice, it can be shorter or longer than the parallel design. In other settings, it can take time to realize the effects of the intervention. So the intervention needs time to start working and affect the outcomes. Now, if this time to affect outcomes might be of considerable duration, particularly in settings of complex interventions, then in those types of situations, the stepped wedge design might not be a good choice. Now, there's one common misconception. So we saw in the review that a substantial or non-significant minority of studies reported that the stepped wedge design was used because of its perceived ethical advantages. Now, the stepped wedge design is often thought to be ethically appropriate when the intervention is expected to do more harm than good. But if we think about this for a little while, so if we're thinking about doing a stepped wedge design, if we think there's a strong ethical argument to give everyone the intervention, then we probably should give everyone the intervention and not evaluate it. So this justification for using a stepped wedge design that is ethically more appropriate when the intervention is expected to do more harm than good is actually a myth, and it's not a good justification. So let's have a look at a case study now. So this is the Porsche study. Remember, this is a cross-sectional stepped wedge trial evaluating the impact of a prognostic model for detection and management of particular type of pancreatic cancer. So the design shown on the left-hand side included 17 clusters. Each cluster was allocated to its own sequence. So there are 17 sequences, and the time is divided up into 18 periods. Clusters were cancer care centres, and the intervention was a risk prediction algorithm, so delivered at the level of the individual. Design used cross-sectional sampling, and there was no individual participant recruitment. And the outcome was major complication of the surgery, and this was routinely recorded. So was the stepped wedge design justified in the case of Porsche? Well, it provides a way to distribute a scarce resource fairly, or maybe the intervention was to be rolled out irrespective of any evaluation. We can also ask ourselves whether it enhanced the acceptability of a randomised evaluation. Did it create a logistically feasible design? And did it have increased statistical efficiency? So other things to think about as well are study duration and how long it would take to realise the effect of the intervention. So let's think about these things in turn. So the first potential justification is that it provides a way to distribute a scarce resource. Now, in the setting of the Porsche trial, there appeared to be no plan to roll this intervention out to all the cancer care centres outside of the trial setting, and there was no need, therefore, to distribute a scarce resource. So in this trial, it probably wouldn't be appropriate to justify the use of the stepped wedge design on the grounds of the distribution of a scarce resource, or that the intervention was going to be rolled out irrespective of any trial evaluation, and the stepped wedge design was thus adding a randomisation robust element to it. So this is probably not a good justification in this setting. The second justification is that it enhances the acceptability of a randomised evaluation. So in the Porsche trial, this risk prediction algorithm might have been externally validated. And if it had been, so local stakeholders or the cluster gatekeepers might then hold the view that the intervention was desirable. Now in the Porsche trial, all of the clusters agreed to participate. And whether or not this would have been the case under a parallel design is an unknown counterfactual. So it's unclear in this setting whether the stepped wedge design enhanced the acceptability of a randomised evaluation in the case of Porsche. The third justification is that it can create a logistically feasible design. So in the Porsche trial, the delivery of the intervention involved training, and the initial introduction of the intervention had some resource implications. Now, if the team of experts involved in the delivery of the training and the rollout of the intervention was small, then they might lack capacity to roll this intervention out to more than a handful of clusters at the same time. So therefore, the stepped wedge trial might have created a logistically feasible design. But it's also worth remembering that the design might have been feasible under a parallel design in which at several randomization points a subset of clusters are then allocated to the intervention or the control. The fourth justification is that it has increased statistical efficiency. Now, in the Porsche trial, there are only 17 clusters. It's unclear whether there are other potential centres, but in a small country like the Netherlands where this trial was set, there might not be. So 17 might have been the only clusters that were available. The study might also have been limited to a maximum cluster size constrained by the number of eligibility over a, say, 2-year period, a period in which the funder required the investigators to report or conduct their trial over. So under realistic sample size calculations or assumptions, 90% power might not have been available under a parallel design, but might have been achieved under a stepped wedge design. So it might have well been the case that the stepped wedge design was statistically more efficient in the case of Porsche. And in future sessions, we'll work out on a case-by-case basis how to work this out. Other considerations: study duration. So this study was likely constrained to report within a short time frame. So the study duration was only 91 weeks. Time to realise the effect. It's probably going to be quite a short time to realise the effect of this intervention, which was a risk prediction algorithm. So these things might or might not have been a good justification for using a stepped wedge design, but definitely are things worthy of consideration. So was it justified in Porsche? Probably unclear. So there was no apparent plan to roll out this intervention in absence of any evaluation. The stepped wedge design probably didn't enhance the social acceptability, or at least it wasn't reported to. So there was little evidence that the provision of this intervention to all of the clusters would have made this a socially more appealing design. It almost certainly looked to have some logistical appeal, but whether or not this panned out in practice is another question. And power, it's possible that with only 17 cancer centres, it might not have been possible to achieve the required level of power under a parallel design. But we didn't work that out, and that does need to be worked out on a case-by-case basis. Remember the Gambia study that we started these batch of lectures with? Well, let's think through whether this was well justified. So as a reminder, the Gambia hepatitis intervention study. This was a nationwide trial of the HBV vaccine, and the vaccine program was rolled out in a phased and random way over a 4-year period from 1986 to 1990. And the outcome was a form of liver cancer, and this was ascertained from a national cancer registry with about 30 years worth of follow-up. The investigators adopted this design, they said, because instantaneous and universal vaccination in the country was impossible for logistical and financial reasons. The right-hand side illustrates the trial design. We've got our 17 geographical regions across the Gambia, coincidentally the same as in the Porsche trial. And then the vaccine program was gradually rolled out across these 17 regions in a randomized way, in such a way that babies born in regions that had not yet been rolled out to the new vaccination program were not vaccinated. There were about 63,000 babies born under that control condition, and the 61,000 babies that were born after their region had rolled out the vaccination program were offered and given the intervention. So was it justified? Well, remember, first of all, we have to have a justification for using cluster randomization. Now, in this setting, the intervention is a vaccine. It's actually an individual level intervention, but no doubt there was an interest in the direct and indirect effects. So this is a good reason to adopt a cluster randomized trial. Was the stepped-wedge trial well justified, or would it have been feasible to use a parallel cluster randomized design? So there was very possibly evidence of effectiveness in other settings of the HPV vaccine. And so the fact that every cluster would ultimately receive the intervention was likely appealing. So it probably has some sort of social appeal. That's not to say it's a more ethically appropriate design, but a more socially appealing design. But more importantly, the stepped-wedge design probably allowed a randomized evaluation in what otherwise would have been a rollout without any randomization. So in summary then, the stepped-wedge cluster randomized trial is a pragmatic study design. It's becoming increasingly common. It's got numerous methodological complexities, and it's likely at increased risk of bias compared to the parallel design. So the choice of the stepped-wedge design over a parallel design does need careful justification. So here are the methods references that I've cited, the study references that have been cited. And up next, in session 3, we'll think about the implementation of the randomization and other design-based considerations in cluster trials.